So the anterior approach to the disc, this is Philip Jung's preference. For 2 to 5, he likes to do OLIF. 5-1, he prefers to do ALIF over OLIF. 2 to 5 to S1 is OLIF, and then anterolateral OLIF, I guess. So the side of approach, for ALIF, it's retroperitoneal, then midline. So for 5-1, you can go on both sides. Usually for 4-5 and above, we go on the left side. For XLIF, you can go bilateral. This is the OLIF 5-1. You've already seen this, so we'll just skip over it. You know all about this. So preoperative planning, important to identify the veins. The arteries are mobile. The veins are usually trickier, so you have to identify the veins if you're starting off. And the right or left side approach depends entirely on these vessels. So lateral decubitors, some people will break the table. I don't. I think Philip does, but I'm not sure. And then fluoroscopic location of the disc. So you mark the skin marking. Dr. Kotani explained this earlier. So we'll just speed up. And this is the corridor that we're all talking about. So unlike traditional ALIF, and even ALIF, you can go midline or you can go paramedian. You can actually approach lateral to the rectus. I've seen a lot of people do that. I don't do that because I'm worried about denervating the rectus. So I like to go linea alba. So OLIF actually is a modification of the lateral rectus incision, except you're going in from the side. And the benefit is that in obese patients, the abdominal contents will drag, and it'll be a very short approach to get to the disc. So you can palpate the incision anterior to the ASIS and just make the skin incision here to get to the L5S1 disc space. And just handheld retractors. There's often a median sacral artery which needs to be taken down, and then it's just use the retractor just segmentally and just retract the peritoneal contents off, and you get to the disc space. And we can clamp the vessels. We can clamp the retractors to the drape, and this is it. So some people will use a ring. Philip here has used a rubber band to secure to the drape. So lots of variations. And you've got your disc space exposed. This is anterolateral ALIF. You have to beware of any vessels, such as this. This is probably the common iliac vein on the left. And retract that away, and then you've got the disc space. Cage preparation, and locked in with screws in front. And that's the skin wound. So it's about a 5 centimeter incision, 5-6 centimeter incision here. And this is at 6 months, fused up nicely. And also additional 4-5 OLIF as well here. So this is another patient with a lytic listhesis here and vacuum sign at 4-5. So I guess this would be at a minimum 2 level. This is the setup. So again, let's use a different retractor this time. So the approach to 5-1, and that's the result. So it's a 3 level. It's done 2 OLIFs above and a anterolateral ALIF at L5S1. Lots of terminology. Some people call it OLIF, some people call it anterolateral ALIF. Another one, 3-level pathology. So L5S1 is also fused because we don't want to, that's also, that's the preoperative. So conventional ALIF, this is done anterior. So Philip does both. And the advantage of this is that, again, there's no posterior disruption. And this true anterior approach allows complete discectomy. So you can completely remove the disc. Even with the anterolateral ALIF, I cannot completely remove the disc because you just can't see the corners so well. So you're missing the corner on both sides. But for ALIF, you can actually remove everything. And this allows the biggest of all cages. So that's the benefit. The disadvantage is that you have to go midline to do this. So you go straight through here, and you can go everywhere. You can release everything, which is necessary if you're doing a total disc replacement. And this is the result. And this one is locked down with screws. This is a lysis. So it also allows removal, direct visualization of the spinal canal. So you can remove a herniated disc, in this case, or even a sequestrated disc you can remove from the front. So, 1 minute left. Okay, so this is a total disc replacement, and he's removed the sequestrated disc fragment as well at the same time. So in conclusion, the anterior approach to L5S1 can be oblique or can be direct midline anterior. OLIF 5.1 is an easier approach. There's less visualization, but it still enables very, very big cages. But it's hard for challenging vessels. So a traditional ALIF is better for vessel when you need to do vessel mobilization, when you need to do vessel release. Sometimes we'll release the vessel subperiosteally. And it also allows a complete visualization. So there are benefits of both. If you're doing lateral surgery, go with the lateral ALIF. If you're going midline anterior surgery, you can do the traditional approach. Thank you.